who can introduce Xavier and then start the webinar. Thank you.
Thank you, Thomas, and it's a real pleasure being here and having the possibility to attend with all our residents these seminars. And today it's also my great pleasure to introduce Professor Xavier Monnet. He is a full professor in intensive care medicine at Paris St. Clair University, and it works in the medical intensive care unit at the Bicêtre Hospital. Professor Monnet main fields of research include acute circulatory failure and its treatment, hemodynamic monitoring, and heart and lung interaction. He is he authored numerous book chapters, review, and almost 300 scientific peer-reviewed papers. And to tell you the truth, I always make a point of attending his conference presentation because they are not only insightful and almost always beautiful to see, but also remarkably clear. So it's a great pleasure having him here. And please, Xavier, the floor is yours with the two-day seminar titled Fluid Resuscitation in Septic Shock. Anything new? Thank you.
Grazie Alberto, grazie a tutti. Can you now see my screen, shared screen?
Yes.
Yes, you see the full screen slides, right?
Correct.
Indeed. So we'll speak about hemodynamic monitoring, fluid resuscitation. I'm sorry, and indeed I disclose my conflicts of interest, mainly of the companies developing some cardiac output monitoring devices, but it's not exactly our topic today. Because we'll speak about fluid resuscitation, and so I decided to, I could speak very formally on fluid responsiveness or the types of fluid or some classical presentations, but I said to myself, if they want me to say something about what's new, we must speak about the fluid balance. Indeed, let's take the example of a patient with a septic acquired pneumonia. And of course, this patient will receive fluid first treatment. In your ICUs as in mine, I'm absolutely sure that you have in today when fluid patients is this risk of increasing the fluid balance, of inducing fluid overload. Regarding this risk and the possible of the fluid, especially in septic shock, because it's our topic today, I'd like to get through three messages. The first one, and perhaps the most important one, is that fluid accumulation is indeed harmful in critically ill patients. That's something very important to have in mind indeed. I mean, we have today many studies telling us the risk of giving too much fluids to our increases abdominal pressure, it increases central venous pressure, so it decreases the perfusion pressure of the organs, it promotes acute kidney injury, right ventricular failure, and likely the most dangerous effect is that it promotes lung edema, which is particularly dangerous in our patients with acute respiratory distress syndrome. And we have, as a consequence, we have today a lot of studies telling us that the more you give fluid to your patients, the more they die. That's only one of these studies, but especially during septic shock, during ARDS, it's well demonstrated that this fluid accumulation, so the increase of the total fluid balance, is dangerous, harmful for our patients, and is likely something independently linked to the risk of dying. In spite of that, you may know that all the studies that attempting to reduce mortality by using a restrictive fluid strategy compared to a liberal fluid strategy, especially in septic shock, have shown to be negative. All the attempts to reduce this fluid accumulation in a protocolized manner in randomized controlled studies have been negative. In spite of that, I think that reducing this fluid balance in septic shock is possible, but it must be active, so it must be really, it must use several ways, and it must be personalized, and that's what I'm going to show you. When we speak about the fluid balance, what are we speaking about in fact? We speak about the fluids we give during fluid resuscitation, the fluids we also give to optimize the hemodynamic status. The difference between both is not that clear, but we still give fluid for stabilization, and we sometimes remove fluid for evacuation when the patient's been stabilized. And so this fluid balance is this red curve. And so if you understand the risk of giving too much fluid to your patients, you may say to yourself, one of my mottos may be to reduce the area under this, this red curve, that's using the fluid balance. The first issue is about this initial fluid resuscitation. You've all read the Surviving Sepsis Campaign guidelines of the 2021 version. When a new version is in preparation, I don't know what it will or what it will recommend, but at least we'll live on this 33 recommendations, 30 milliliters per kilogram within 3 hours for our septic shock patients. That's the initial fluid resuscitation. However, I think that we may be much more specific to the condition of the patient. No single formula based on weight, just individualize this initial fluid therapy, the initial volume you give for the patient. And the reason is just absolutely obvious. Because indeed, why do we give fluid initially to our septic shock patients? Agree with me, we want to compensate for hypovolemia. There is the relative hypovolemia, which is due mainly to venous dilation, and the absolute hypovolemia, which is due to capillary leak and to the fluid losses. However, it is obvious to any clinician that this absolute hypovolemia must differ among the patients. It cannot be the same in a patient with peritonitis with vomiting for 3 days and in a patient with community-acquired pneumonia, the example I took. And of course, the volume of fluid losses must be different. And so obviously, the initial fluid needs of the patient cannot be the same. It cannot be only a matter of weight. To show that we are conducting this study. It's a very simple study, and with some colleagues, including, as you see, some Italian colleagues, and especially Simone Capio. In our center and other centers, we are measuring the volume of fluid we give to septic shock patients from the very beginning until they become fluid unresponsive. Saying to ourselves, okay, that's likely the initial fluid volume that they need, okay, because we give fluid, they are fluid responsive, then you repeat fluid infusion, they are still responsive, etc., until they become fluid unresponsive. Let's say that it's likely the volume of fluid needed by the patient once again. Look at the slide, different depending on the origin of shock, and not surprisingly, it's higher in the case of abdominal sepsis, for instance. But perhaps more interestingly, that's the repartition of this fluid volume in the population. It's quite interesting to see that on average, it's 30 milliliters per kilogram. So it's likely meaningful, this threshold of 30 milliliters per kilogram, but it's only an average, showing that it's too much in half of the patients and not enough in half of the patients. So with this volume, you under-resuscitate some patients, but over-resuscitate some other patients, which is perhaps even more harmful. So why not personalizing? And for this purpose, we observe that when you give only 10 milliliters per kilogram, all patients after this fluid bolus still remain preload responsive. So nobody counts in milliliters per kilogram, let's say 500 to a liter of fluid, and then again assess fluid responsiveness again. And then you will be sure that you will give enough fluid to your patients and not too much fluids to your patients. And that's likely something very, very important to bear in mind. Okay, so individualize the initial fluid volume. Then, as I said, your motto may be to reduce this total amount of fluid you give to the patient, the fluid balance. The first way to do so is likely to give no ineffective fluid. I mean, to individualize after the initial fluid therapy, the volume you give on fluid responsiveness and avoid giving fluid to unresponsive patients. It means detect preload responsiveness. Two messages regarding this. I told you my presentation will not be focused on this specific issue, but one message is that fluid responsiveness disappears quite rapidly. It's an interesting sub-analysis of the Andromeda shock study. Yeah, the first one. Huh? You see, so they gave fluid initially as initial fluid resuscitation, and then after, in some patients, they were able to measure the time until when the patient became unresponsive. And you see that 2 hours after this initial fluid resuscitation, fluid responsiveness was present in only 36% of the patients. In all the other ones, the initial fluid resuscitation had led to fluid unresponsiveness, and these patients were not responsive anymore after only 2 hours. So we must test fluid responsiveness rapidly after initial fluid resuscitation and not too late. The second message is that we have today different ways for assessing preload responsiveness. I will not get through all these different ways, but you know that the principle is likely that, in fact, the principle is that you change preload in any way and then assess the response in terms of stroke volume or cardiac output. And it would tell you the slope of this Frank-Starling relationship. If cardiac output doesn't change that much to the stress of cardiac preload, if the change in stroke volume, cardiac output or surrogate is below a given threshold given by the literature, you will tell yourself, my patient is not responsive anymore, I will not give fluid. On the contrary, if the test is positive, you will go on fluid infusion. And today, for changing preload responsiveness in our patients, we have different ways. You can mimic a fluid challenge with a mini fluid challenge with passive leg raising, which is likely the best established test of preload responsiveness. Or you may use the ventilator, typically with the tidal volume challenge on the new PEEP test that we developed quite recently, using heart-lung interactions. So to say that today you have different ways to do that at the bedside, and may adapt the test to the condition of the patient. You can use in non-ventilated patients, you can use passive leg raising or the mini fluid challenge in patients with ventilation but spontaneous breathing activity. You can use the tidal volume challenge, etc. In patients with high PEEP levels, you can just decrease the PEEP level, that's the PEEP test. You have different ways depending on the patient's condition and the cardiac output monitoring devices you have. The last message regarding preload responsiveness is that it may be efficient. Many people said, okay, if it doesn't change mortality in the patients. It's not exactly true. These are the studies that tested the outcome effect of testing preload responsiveness, and they showed regularly that it allows you to decrease this fluid balance. I take the example of this FRESH study. It's a study conducted in the US and in the UK, and they tested preload responsiveness from the very beginning of septic shock by using passive leg grazing from the emergency department. And in the end, you see that these patients receive less fluid. Indeed, it works. By predicting fluid responsiveness, you reduce the fluid balance. And by the way, they also reduce the needs for renal replacement therapy and for mechanical ventilation. So that's meaningful. The second way to reduce the fluid balance may be to increase fluid efficacy. I mean, by giving norepinephrine early. Why? What do I mean? Of course, in the majority of your patients, the second treatment will be norepinephrine. And the daily question is, well, start norepinephrine in this patient? Typically, should I wait for the 30 milliliters per kilogram fluid infusion? Should I start earlier, etc.? For answering the question, we may consider what are the pharmacological effects of norepinephrine. Indeed, when you give norepinephrine, it's basically for increasing the arterial pressure. And you will agree with me that the first thing that you expect is that it fixes the arterial alpha receptors to increase blood pressure, to induce arterial constriction. But bear in mind that the veins also have some alpha receptors, and mainly alpha 2 receptors, that will induce venous constriction. And this venous constriction may be very important when you speak about fluid infusion. Why? Because if you represent the venous system in this way, with this very large reservoir here, and here of course the right and the left cardiac cavities, when you give norepinephrine, and by the way, the same for the norepinephrine, endogenous norepinephrine of the patient, is that it will stress the venous walls. And in this way, it will increase the proportion of blood which is stressed by the venous walls. It's called the stressed blood volume. And so it will increase the pressure in this reservoir here, which is called the mean systemic pressure. You know, it's the upstream pressure of venous return. It's a determinant of this venous return and of cardiac output. So, in theory, norepinephrine may increase venous return through this venous constriction effect. It's sort of a fluid-like effect. You stress the venous blood of the patient, you recruit cardiac preload, in other words. But that's the case. It's not only theory. In animals, Sheldon Magder has shown that it indeed increases this mean systemic pressure, whatever the way he measured it in animals. For the first time, we showed it in human beings as well. In patients with septic shock, we showed that at a higher dose of norepinephrine, this pressure in the venous reservoir significantly increased. And this effect was not negligible because it was the equivalent of half a liter of fluid. So in this patient, when we increased norepinephrine as a request for daily practice, just for the practice and for the care of this patient, it was the equivalent of infusing half a liter of fluid. And it was nicely confirmed, not in septic shock, but in the post-cardiac surgery context by another team, exactly the same result with the same method. That may be quite interesting because, of course, you may give norepinephrine early first to restore blood pressure rapidly. But if you do, you may also require less fluid because you started norepinephrine earlier. Through this fluid-like effect, I give norepinephrine, it's like giving fluid. However, it may be even better because once you have started norepinephrine, the venous reservoir is then constricted, you will agree, and so the next fluid infusion will not dilute in a very dilated venous reservoir. It may be more efficient. It may increase the mean systemic pressure to a larger extent. That may be the synergic effect of norepinephrine and fluid. And in this other study, again in septic shock patients, we showed that indeed, not fluid infusion, but passive leg raising, a pseudo-fluid challenge, was more efficient on the change in mean systemic pressure at a higher dose of norepinephrine compared, at a higher dose of norepinephrine compared to a lower dose. So it may mean that once you have started norepinephrine, the next fluid challenges will be more efficient. For the moment, we don't have a strong evidence through big RCTs focused only on mortality and early norepinephrine administration, but we have some RCTs and some observational studies. We merged them recently in a meta-analysis in critical care, showing that indeed, even if you take only the RCTs and the propensity score-based studies, and or if you add the simple observational study, you improve mortality, you improve survival, with this early norepinephrine administration. At least if you trust this meta-analysis, for sure, we need some larger RCTs focused only on mortality and early norepinephrine administration, but at least this is what we have for now. So likely early, not in all the patients, likely in patients with who are very vasodilated, for instance, as indicated by very low diastolic blood pressure below or equal to 40. Perhaps you may consider this diastolic shock index. It's the ratio of heart rate over DAP, and it's an index of vasodilation that may be even better than this diastolic blood pressure alone, at least something that tells you the patient is vasodilated. So not for all the patients. In a patient with severe septic shock with a very low blood pressure, a very low diastolic blood pressure, a high diastolic shock index, not for a patient for a simple, if I may say, urinary sepsis and less stronger vasodilation. You may wait. This is exactly what we have suggested with Daniel de Backer and others in this position paper. Yes, perhaps think about giving norepinephrine early in the case of life-threatening hypertension, low DIP, low increased diastolic shock index, and of course in the patients with a high risk of fluid overload. This must be individualized. A third way to reduce this fluid balance, indeed, may be to stop fluid when it is too dangerous. I think that's a step that's often missed, and that's why I insist on that. I mean, let's imagine our septic shock patients. We are now, 12 or 24 hours after fluid infusion. And the patient is ventilated with a PF ratio of 100. Should I give more fluid to this patient? To limit the risk of fluid overload, I must have in mind some indices of fluid overload. You must look at either, so PF, it's not very specific of fluid overload, but you may look at the high central venous pressure. You should measure CVP in your patients just for this purpose, even the high intra-abdominal pressure in patients with abdominal problem, or lung water if you measure it with a PICO device or transpulmonary semi-dilution. And we showed in another meta-analysis, by the way, with Francesco Gavelli, that indeed it is a factor which is associated with mortality in critically ill patients, it makes sense to decrease the lung water by giving less fluids. Of course, if you want to be fashionable, you will consider this Vixus index. You may all know that, I'm sure, because it's, again, everyone speaks about that. With echo, you measure the diameter of the IVC. You look at the hepatic vein, the portal vein, and the intrarenal vein Doppler. And depending on the aspect of this Doppler, you say there is venous congestion. And indeed, we showed recently in the study, it's now under review, that you see in patients who are who are mainly fluid responders. So you give fluid, they respond. This Vixus score is quite normal at baseline and very uncommonly increases. On the contrary, if you give fluid to patients who are non-responders, they are more often overloaded with venous congestion, and perhaps more importantly, in the patients with a quite low Vixus score, it increased with fluid infusion. Definitely, fluid infusion worsens venous congestion in a majority of fluid non-responders. One should not give fluid to unresponsive patients. So again, you must have that in mind. You must consider, for instance, CVP. You must consider the lung water if you measure it, lung permeability, and perhaps this Vixus score. If CVP is only 10 in a ventilated patient, lung water, for instance, just above 10, you may give one more fluid challenge, not in patients with signs of fluid overload. So you must look at that, and especially I insist on the value of central venous pressure for this purpose. The fourth way would, of course, be to avoid unnecessary fluid infusion at a later phase. I mean that when the patient is stable. This may mean reduce what one calls the maintenance fluids. What do I speak about? You know, we give fluid for fluid resuscitation, but also a lot for just diluting the drugs, for feeding the patient, just for keeping the venous lines open. A lot of the fluid volume we give to our patients in septic shock come from these maintenance fluids, which of course we may reduce. This is a very interesting observational study conducted in a large population of critically ill patients. Be careful, not only shock patients, but you see that. They wanted to know where fluid comes from. And they observed that half of the fluid we give were these fluids for diluting the drugs, for diluting electrolytes, for feeding the patient, etc., for keeping the venous lines open once again. A large majority. Maintenance fluids, by the way, is very difficult. You may change all the protocols in your ICU for giving more concentrated enteral nutrition, for reducing the dilution of your drugs, for giving normal fluids to keep the venous lines open. That's very difficult. Finally, of course, you may remove fluid, and it's likely the most efficient way to reduce this fluid balance, but again, not the same in all the patients. You should individualize, and especially, once again, on the prelude responsiveness status. What do I mean? In this study, we said to ourselves, okay, we will ultrafiltrate patients at the resolution phase of shock. But before, we will test preload responsiveness by a passive leg raising test. And we said to ourselves, okay, if here ultrafiltration, of course, it will decrease cardiac preload. If it occurs in a patient who is fluid responsive, it means that his or her ventricles will decrease their cardiac output with the decrease in preload. Ultrafiltration will be poorly tolerated. On the contrary, if you ultrafiltrate these patients while they are preload unresponsive, they will perfectly tolerate the decrease in cardiac preload without changing their cardiac output. You understand? So preload unresponsiveness may mean good tolerance of ultrafiltration, no intradialytic hypertension. And it was indeed the case, suggesting that before deciding to remove fluids, test preload responsiveness. If it is present, do not remove fluids, do not decrease preload because cardiac output will decrease. And on this principle, the team of Jean-Christophe Richard in Lyon, another French team, conducted this randomized control trial. And they, to summarize, it's a bit complex, but they protocolized fluid removal depending, you see, on passive leg raising. And they showed indeed that the patients, in the patients who are protocolized in this way, they decrease the cumulative fluid balance to a larger extent and more rapidly than in the other ones. And there was no more hemodynamic instability despite fluid removal was more active. So it was only more active but more personalized. Once again, not the same in other patients. A patient with negative passive leg raising at day 7, you think about removing fluids with ultrafiltration. Passive leg raising is negative? Okay, go for fluid removal. Not in this patient with a positive, I'm sorry, there is a mistake here. Not in this patient here with a positive passive leg raising, sorry for the typo. So once again, individualized on the patient physiology. Finally, my friends, my last message. Okay, the randomized controlled trials I showed you who are negative have not tested such an active and personalized strategy. If you look at the protocol of all these studies and at all those interventions, possible interventions, you see that in fact, a majority of them focused on initial fluid resuscitation. None of them tested preload responsiveness, neither for giving initial fluid nor for removing fluid. Very few studies have tested removing fluids, only the RADAR 2 study. They focused mainly on initial fluid resuscitation. In the study I showed you before, it may represent only a minority of the fluids we give to our patients. And so, of course, if the study is focused only on this initial fluid resuscitation, they induced very small differences between both groups. Look, all these large studies here, very small differences between restrictive and a large fluid strategy, here. And so, of course, the mortality cannot change if you change the volume received by the patients to a so small extent. For instance, you know, in the classic trial, only even just a bit more than half a liter difference on day 1. How could it be that it reduces mortality and not much more at day 5? I went for holidays to Japan a few weeks ago. A beautiful trip. I don't know if you've been to Japan, but it's really a country one must visit once in one's life. And I was fascinated by, I don't really know the Japanese people, okay, but my feeling is that what they love is perfection. They want to be perfect for these Japanese gardens, even for, you know, just for making a cup of tea, just for preparing tea. It must be perfectly done, exactly with a perfect move. When they do whisk, it must be absolutely perfect, etc. This, and I mean many of my colleagues who tell me, okay, I've heard all of your talks, you know, and you say that one should take care of all these steps one after the other. In my ICU, I have no time to do that. I even have no tools for doing that. Okay, echo sometimes, not more. CVP, we never measure it, you know. Oh, diastolic blood pressure, oh, we look at the mean arterial pressure. That's far enough. We have no time to do all this for these patients. And I think about these Japanese people. we take care of these patients with a mortality of 40, 50% likely. And I say to myself, why not looking for perfection as well in these patients? Yes, it is not that easy, but nobody said it's easy to take care of septic shock patients. It's not that easy. There are many things to do, but we also do much more complex things in one day in an ICU. If you think about inserting catheters, starting renal replacement therapy, that's not easy. So just let's spend a bit of let's monitor these patients, really open the box and see what's happening in these patients. And perhaps in this way, and especially by using active and personalized ways and all the ways to reduce this fluid balance, we may achieve this goal and perhaps improve the outcome of our septic shock patients. Thank you very much for your attention.
Thank you very much, Xavier. It's always a pleasure for me to listen to you, to your fascinating lectures. Really, a lot of messages. I really enjoyed it as always. Besides the
Thank you,
beautiful
Pierre.
slides that you are always able to show everybody. We have collected some questions from the faculty, but I encourage all the members of the faculty to take this occasion and to ask questions to Xavier, and also encourage all the participants to use the chat box to send us
My
questions.
pleasure, of course.
So let's start with some maybe easy questions. So a practical question. On your clinical practice, how are you using the extravascular lung water index from PICO system in order to somehow guide your fluid therapy and your hemodynamic supportive therapy?
Yeah, it's a good question. In fact, so first in which patients do we set up these transpulmonary thermodilution devices? In patients, in the most complex patients, and not in all shock patients, but in the patients with shock that resists to initial treatment. So you start fluid, you give a small dose of norepinephrine, but the blood pressure still is not restored. Or the patient is complex, has cardiac dysfunction plus septic shock, has severe pneumonia. And so we decide to monitor the patient. If there is right ventricular failure, we go for the pulmonary artery catheter, by the way. If not, we use transpulmonary thermodilution. And indeed, one of the main interest, I think, may be to measure lung water. So not only cardiac output, which is indeed useful, especially when you give fluid, etc., but lung water. And for me, it really helps guiding fluid therapy. Typically, as I told you, as a safety index for fluid resuscitation. If it's very high, we do not give fluid anymore. There is lung water, but also lung permeability, the degree of the pulmonary leak. It's even better because it tells you if I may say, the size of the holes of the pulmonary, of the alveolar-capillary membrane. So again, if the permeability is too impaired, we do not give fluid anymore. We also use it at the fluid removal time. And I was on the round in my ICU just before reaching you. And we were asking ourselves, okay, this patient with septic shock is here for 10 days, has improved from pneumonia. Should we go for fluid removal, ultrafiltrate this patient before weaning? And lung water had already decreased during the last days. It's only 11 today, which is just above 10. And the central venous pressure is only 10. And so I said, likely this patient is not that overloaded. So you see, it tells you, in fact, just the lung impact of this fluid accumulation. That's the main way we use it in septic shock. So to summarize, to guide for guiding fluid therapy.
Okay. And maybe another question related to this concept, because I was struck by your proposal to use fluid responsiveness to guide fluid evacuation. in the last phase, which is always not quite well studied. And I totally agree with you on that. But how can we deal with because normally fluid responsiveness looks at the intravascular compartment. So how can we deal with the accumulation of extra in the interstitial fluid, in the interstitial space? Because sometimes we have patients in which the intravascular compartment does not appear to be maybe so expanded, while we have, fluids in the interstitial phase, in the interstitial space. Go ahead.
Yeah. You're right. I spoke likely too rapidly, and it's not that simple. You're right. Because in fact, if you speak about the fluid you want to remove, it's not only the intravascular fluid, and even not this one, but the interstitial one. However, as you know, if you speak about diuretics infusion or ultrafiltration, rapidly the interstitial fluid, if you ultrafiltrate the patient or remove fluids from the patient, will go to the intravascular space first. However, it's not that simple. Also, you may have some hypertensions that are not related to a decrease in corticoid, but just vasodilation. That's especially when you prime the circuit of ultrafiltration, if you use intermittent renal replacement therapy. But it remains that in a preload responsive patient, when you will ultrafiltrate the patient, and you will agree with me, decrease the total blood volume, you must induce hypertension, and it must be poorly tolerated. It may happen, I agree, that if you do that, okay, the patient is preload. So I agree that if you start a very slow ultrafiltration and then allow this continuous feeling of the intravascular space from the interstitial space, it may be better tolerated. But it remains that if the patient is preload responsive and you decrease preload just by priming the circuit, cardiac output must decrease. In other words, I'm pretty convinced that there are no false negatives to this, okay? No, false positives, I'm sorry. If the patient is preload responsive, it must be poorly tolerated. Okay, if you may convince me that in preload unresponsive patients, it may be also poorly tolerated, but at least by the ways we use today, I mean ultrafiltration, rapid ultrafiltration with a conventional renal replacement therapy or diuretics, we really have a risk of hypertension.
Yes, indeed, I totally agree with you. And another, bunch of questions on the use of vasopressors, because I think it was another important message, the early use of, you have mentioned norepinephrine. So first question, any role also for an early use of vasopressin? There are some, articles trying to suggest also the early use of vasopressin. So what do you think? Would you comment on that?
Yeah, it's a very good question and really an up-to-date question, but still pending. For norepinephrine, we lack, I told you, some very convincing large RCTs, but for vasopressin, the level of evidence is even lower, definitely. There are some arguments for starting vasopressin early, especially because we know that this deficiency in vasopressin, in the endogenous vasopressin, occurs quite early after the onset of septic shock, but we have no study at all for the moment. We have some arguments telling us, okay, perhaps we should give it to the less severe patients, like in the VAST study. In this patients, it's more beneficial, but we lack big evidence. There are some ongoing studies, by the way, on this issue, but for the moment, no clear evidence. So in my practice, for instance, we still use it as a second line after quite small doses, norepinephrine, perhaps smaller than in other centers, but there is no strong evidence. So I don't know your opinion, but I would not go for a straight recommendation on this.
Yeah, but you're right. I think it's probably too preliminary, too early to give recommendations on that. But I was just curious because there is a physiological rationale, but we lack evidence. Yeah, you're right. Related to the use of early use of noradrenaline, and a more probably practical question. So, first question: how do you titrate noradrenaline on your daily practice, especially in order to avoid possible side effects, and on the other side, dealing with the possible resistance that in some patients during the acute phase of septic shock we sometimes see. So sometimes we see patients in which we start to increase the dosage of noradrenaline. It seems like noradrenaline does not work as the beginning, so it's like a resistance to noradrenaline. So how can you deal with this
It's
issue?
again a very unsolved question. Regarding the way we manage it, we do as everyone, I think it means. And it's a very, at least very basic way. Huh? What do? We look at the mean arterial pressure. The nurse looks at the mean arterial pressure and sets the dose accordingly. Increases when it's too low, decreases when it's too high. Which leads to, if you look at the blood pressure trace over one day, that's awful. It leads to, you all know this, hypertension, long times and of deep hypotension, where you increase the dose, and yes, that's life, but that's super, likely super basic. In the future, and we work on this with AI, we will have some closed loops, that will automatically set the dose depending on the patient and the blood pressure. As for diabetics, depending on the dose of, for the dose of insulin, depending on the glucose level. In the ICU, it's only the very beginning for the moment. Regarding the question of resistance, nobody has the answer. In practice, we switch to, or we add vasopressin, and again quite early, and always with a max dose of 0.04, because we think there is no need to increase it a lot. And then if it's still not enough, we increase the dose of norepinephrine. Once again, it's very basic. Perhaps in the future we will have angiotensin which is very, very potent. I don't know if you've used it already. It's a very potent vasoconstrictor, very expensive but very potent. So that maybe, you see, we may have a more multimodal, as one says, a multi-pressor strategy. But for the moment, it remains very basic.
Okay, and related to always to noradrenaline resistance, do you think that noradrenaline resistance may even be related to the possibility of still having capillary leak in an active phase, so that with noradrenaline you more or less increase payload, right? You may increase, as you showed us, you may increase cardiac output, but if you still have capillary leakage, this somehow, you understand? So this may lead to still hypotension.
I read the
Go ahead.
question of Filippo Davino.
Exactly.
The
So
chat,
go
and
ahead.
it's a very good question. It's a good. So if I understand well, the idea would be that by increasing cardiac output and even more the pressure in the vessels, you would increase the leak. If you, I'm not a big specialist of this, but there is a guy whose name is Robert Hahn in Sweden, in Karolinska, who is a very nice and very clever guy who knows everything about these fluid transfers. And he says that the most important is the wall injury. Okay, that's the most important, and the pressure inside, compared to the interstitial pressure, is not that important. There is a decrease in interstitial pressure in the case of sepsis by a change of the structure of the molecules of the proteins in the interstitial space, which attracts a lot of fluid out of the vessels, but it's not that much a matter of the intravascular pressure, which would suggest that it's not a matter of blood pressure and norepinephrine. I know it's not that well demonstrated, so I would be still very cautious of this.
Okay. Couple of questions from the audience. I will read them because I didn't get much that. So the first one, how do you approach patients with multiple comorbidities affecting fluid responsiveness and cardiac function? Well, this is an important question. For instance, atrial fibrillation, aortic stenosis, mitral regurgitation, when you are concerned that the next intervention might do more harm than good. But it's not an easy question, probably not
No,
in,
but
but it's an
it's a very
important one.
practical. It's a very practical question. I see it. There are two different things, I think, in the different conditions mentioned by Simone. First, you have aortic stenosis and mitral regurgitation. You may add cardiac dysfunction. Well, you say to yourself, if I give fluid, the risk is very high. Okay, because in patients with shock, it's not a big issue. If your patient is preload responsive, and if you trust these different tests, it means that you will give fluid and cardiac output will increase. That's all. It does not tell you the risk. Then you may weight the risk on the other side. Say to yourself, okay, this patient is but it remains that low cardiac output is very dangerous even in a patient with aortic stenosis. So you say to yourself, if I give fluid to this preload responsive patient, cardiac output will increase. And you weight the risk in another way. The issue of atrial fibrillation is likely a bit different because it makes some of the tests of fluid responsiveness ineffective or unreliable, and we mainly speak about pulse pressure variation, or the tidal volume challenge, which uses pulse pressure variation, or the changes in pulse pressure variation induced by passive leg raising, for instance. So all these indices based on PPV, you have many false positives with atrial fibrillation. So you see, it's another issue for me. It's the issue of the unreliability of fluid responsiveness indices. Regarding the cardiac problems, again, it's your decision. If in this patient cardiac output you think it's too low, you must increase it in any way. It's not because it's a cardiac patient you will not do it, and fluids may be the solution. The risk is another question.
Okay. A couple of questions on the target that we may use on fluid therapy and vasopressors. So the first one is on a practical basis at the bedside, how can we measure, if it's possible, mean systemic field pressure?
It's a good. I'm not sure it's okay. That's the pressure in the venous reservoir. You will know this. So it's upstream and blood flows, as on my picture, it flows from this reservoir to the right atrium. Of course, there is no reservoir like this. It's only a theoretical view, and so is theoretical pressure. However, it's a very important pathophysiological variable. Not sure it helps you guide your treatment. I would, for instance, I would like to know it if I give norepinephrine to just assess the venous effect, but I don't really need it. I would like to see it if I give fluid to see that indeed it increases, but it's not absolutely mandatory. So not sure it is useful at the bedside, first. Second, how to measure it. Let's imagine that you're convinced that you need it at the bedside. There are different ways. The best way is to create cardiac arrest, and you measure blood pressure, and then in the next seconds, it will go down to this mean systemic pressure. But okay, it's not very ethical, huh? So you may use the ventilator, for instance. So we used a complex ventilatory method, time consuming, it's only for research. And finally, there are some people who believe in a formula based on a cardiac output, mean arterial pressure, and central venous pressure, a formula you can find on the internet. There is even an app that may calculate it. And that tells you an estimate of this mean systemic filling pressure. I would say at the bedside, if you really trust that it's something interesting, use this Perkin, P-E-R-K-I-N formula, Perkin formula, and you can find it. It depends on sex and demographics you see, and anthropometry, but it's quite easy to calculate.
Okay. Okay.
So, but again, I would not, you know, years ago there was a company that developed, likely Stefano remains that has developed a machine that measured cardiac output, mean arterial pressure, CVP, and there was the formula inside. It was called the navigator. You remember, Stefan? And so they said, "Oh, it gives you mean systemic filling pressure," and nobody bought the machine because there was no clear interval. So they stopped, and now the formula is available on the internet.
Okay. Stefano, do you want to comment on that?
First of all, I want to thank Xavier for the fantastic lecture. I'll tell him hello. So really a great pleasure to see you. Just a very quick question. Do you think, because I see in my screen you and my friend Pietro, is there room for early administration of albumin in fluid resuscitation in septic shock patients? How do you see the use of albumin outside the surviving sepsis guideline recommendations?
Oh, you likely know better than me, and the question may be better for you, I think. My view is that did we really answer the questions with the big studies, and especially with Albios?
Oh, wow.
But,
okay.
do we really, and did we really answer all the questions? The problem, I think, is that if we used albumin at a very high volume, especially for fluid resuscitation, that would become very expensive. And I think we would only speak about a few patients where we could use it. For instance, of course, when you give fluid, you know, at each time you give half a liter of fluid, you induce very significant hemodilution. No? We observe that you decrease the oxygen delivery by 5 to 10% in non-responders if cardiac output doesn't change. That's a lot. And so, of course, this hemodilution is also for albumin and with all the consequences, immune, pharmacological consequences, you know. In these patients where we give a lot of fluid, typically, or a lot of fluid rapidly, is there any advantage? It's not demonstrated. In our practice, we use quite a lot of albumin, especially during ARDS, without any more demonstration. But again, I would like to have your opinion on this.
And Xavier, maybe related to this issue, how about the use of albumin in the evacuation phase, not in the early phase?
Yeah.
What do you think?
Indeed, very, very, because in this patient where the capillary leak has decreased, okay, so you may imagine that it stays in the vessels, and you give diuretics, and you try to attract more fluid from the interstitium, etc. That's meaningful. Not tested as far as I know. And at this time, again, all these patients where you evacuate fluid are hypoalbuminemic because they have been hospitalized for days, they are hemodiluted. Yeah. So yes, that's typical the question situation one. You remember the study of Greg Martin in the US giving diuretics and albumin to decrease lung water in ARDS. It's not been repeated on a large scale as far as I know. Do you use it in some of your patients at the evacuation phase?
I actually have some conflicts of interest, I guess, since
Yes,
we
but,
are quite close to yeah, I'm using it actually. As a practical question, I'm using it. I totally agree with you that we do not have so far strong evidence supporting that use, especially no trials have tested that specific phase. Because also in the Albios 1 trial, but also in the Albios 2 trial, we have started from the very beginning the supplementation of albumin, but not just focusing on the evacuation phase. So I think it could be kind of different issue, and you are right. But in terms of pathophysiological rationale, I think it's there. The evidence are still lacking. You're right. And related to the fluid, there is another question from the audience regarding the possible use of balanced solutions as opposed to normal saline. Do you think we have enough evidence to avoid the normal saline, or what do you think?
So you see, it's a very tough debate. Huh? So I will be very cautious in my answer. If you use only balanced solutions, you're right. If you use saline, especially initially in patients where you think you will not give too much fluids, so small amounts of fluids, nobody can tell you it's wrong for the moment. Huh? You know all the studies, and so provided that you do not give too much saline, it's likely not that sure that it will induce acute kidney injury or even worsen prognosis, survival of the patient. So if you started with saline, we do not use saline anymore in my unit. We used it. We use Ringer. Okay, not sure we need the more expensive balanced solutions, but even just Ringer is okay. But if somebody would tell me, okay, in such patients with pneumonia, you know, they receive only 3 liters during the first day, I use saline, I would say, okay, there is nobody can tell you you're wrong. What's your opinion, Pietro, on this?
Oh, wow. Gee, no, actually, I have always conflict of interest, always for the same study. But, well, so far, I must admit that I agree with you. The evidence we have are not really conclusive and probably not convincing to me. Probably the extent of the treatment effect and the difference between normal saline and balance, especially in an heterogeneous population of critical ill patients, is quite probably lower than expected, is minimal. My early opinion is that probably we have dealt with this question in a wrong way. So probably we should have focused on specific categories of patients. If you look at this question in the critical ill patients altogether, you dilute the real effect. This is my idea, and this is why actually we had decided to design the Albus balanced trial. No, just on septic shock patients.
Because it's a more clever study.
Yeah.
And did you specify? Yes, you have subgroups depending on the volume of fluid given. So I guess that we will have the answer in it.
Yeah. Probably the last question for you, Xavier. Which targets we should look at for resuscitation? Lactate, capillary filling pressure now.
You all know the answer.
Arterial PCO2. No, just go ahead, please.
You all know the answer.
This is a question for you.
These patients are so complex, you know, and their mortality is so high. Again, we speak about patients with a mortality of 40%, even more. So for the price it costs, I prefer to look at several indices. They are not the same. Capillary refill time tells you reactivity of the vessels of the skin. Okay, that's all. SVO2 really tells you tissue oxygenation, lactate, anaerobic metabolism, and the same for the PCO2 derived indices. So I like having all of them under my eyes. It's likely better than stupidly focusing on one of them. After Andromeda 1, who stopped measuring lactate over the world? Just for replacing it by capillary refill time, it costs nothing. Of course, in some very low-income countries, that may be justified, but in our countries, no. So I prefer to have all of them under the eyes, interpret them properly, knowing that this is not the same as this one. Huh? It's a different, and to have a completely view. The more and more I think about all these patients, the more I think it would be a mistake not to open the box and look at what's happening and just looking at, you know, blood pressure and capillary refill time or mottling. I think they require more. I spoke about the Japanese way, likely, of thinking about all these things. You should do your best, and it means looking at several indices and not oversimplify things. So all the indices together. I'm sorry, it's not simple,
No,
but
no, no.
that
Thank you very much, Xavier. I will leave the stage to Professor Bignami, to Elena, that who wants to say greetings
Ciao,
to
Elena.
us. Elena, go ahead. You are muted, I guess.
she'll speak with hands. You cannot unmute her? I don't know, Catherine.
Thomas, no,
No,
Thomas
I
maybe, but
cannot. She has to mute herself, if possible.
Ah.
Work. Well, let's say in the meanwhile, I can, while Professor Bignami unmutes her microphone, I would like to thank Xavier as well. It was really a beautiful, beautiful webinar as always.
Okay.
We had more than 300 attendants, so this is really a record for us. And it is clearly a recognition to your knowledge and your great way of presenting data. So thank you. And this, as said, we recorded this webinar and it will be in our YouTube channel as soon as possible, in a couple of days. So all the colleagues and residents that could not attend today will have a chance to see it afterwards. And I'm also very happy to announce the next webinar, which will be held on the 11th of December. It's a Thursday as well. And we will have the great honor of having Professor Lorenzo Berra from Boston. He will talk about inhaled nitric oxide. So we are really looking forward also to this next webinar. With that said, I've seen that Elena was able to unmute the microphone.
Xavier,
Yeah.
Pietro, it's okay? Okay. Xavier, thank you for this important meeting and very interesting. It's important to discuss clinical and real life topics as you know, there are many young people, and this meeting is essential and crucial for our lessons and educational meeting. Again, thank you for from also Seattle, Italian anesthesiology, and thank you. See you next time with another important topic in ICU. Thank you so much.
Grazie ancora a tutti, è stato un piacere. Ciao.
Thank you. Thank you.
Bye, Xavier. Thank you, everybody.
Ciao, Xavier. Thank you very much.
Your
Yeah.
residents are
Thank
very
you.
lucky. They are very lucky to have these
Yeah.
these webinars with the YouTube channel, you know.
Yeah,
Good
yeah.
idea. Ciao.
Thank you.
Thank you so
Ciao,
much.
Xavier.
Bye. See you next time.
Bye, bye, bye.
Ciao a tutti.
Bye to everybody.